to bring some health care out to all the people who are listening. We are a group of Black physicians that are basically, we have two primary goals. Number one is to increase the health awareness of people of African descent. And number two is to encourage young Black males to go into medicine. We really need those young brothers to go into medicine because in the future, we're going to be lacking Black males. So gear it up. Come on, join us, become a physician. There are other things that I must say before we get started. Number one, and this probably is the most important thing that I'll say during the whole webinar, please do not change any aspect of your medical care until you consult your physician. It's so important because only your doctor can truly take care of you from a medical standpoint. Our webinar is every second Saturday at 1 o'clock. And please tell family and friends. You know, it takes a village to build something like this, and tell family and friends about it. If you would like to see our past webinars, you can go to OBHealthy, that's OBHealthy, healthy, all one word, and scroll down to the YouTube. Our YouTube videos are there. You can review all of our past videos, all right? Now that you've joined, if you've joined so far, don't hesitate. Please do not hesitate to type in your medical question because we're here to answer that question. And that's a focus for us and we enjoy doing it. So please type in your medical question already. I'd like to thank OBHealthy for allowing us to use their platform so that we can bring this webinar to you on a monthly basis. All right. I think that's just about it. And I see that Dr. Sprocket just joined us. Kendall, can you just say something so we make sure that you're...
Yeah, Kendall Sprott.
All righty, excellent, thank you. What this webinar is, I'm excited about it because we have a guest physician coming in talking about radiology and what happens in the radiology department, what kind of x-rays, CAT scans, PET scans, MRIs, things like that. We all, as physicians, send our patients to get these done. But it would be nice if you, the public and all of you out there know exactly, number one, why we send you, number two, what's expected, and just what we're going to get from that particular procedure or study that can help you from a medical standpoint. So I'd like each and every physician to introduce themselves. Dr. Delaney, you are the first one on my screen, so I'm going to call you in to introduce yourself, and we will go from you and go to the other docs. So please.
Hey, I'm Michael Duhaney. I'm a radiologist, diagnostic radiologist for many, many years now, since 98. Started working in private practice in 1999 in Wayne, New Jersey. I'm a neuroradiologist by subspecialty trade, administrator also. I'm the system chairman for CarePoint Radiology, which runs Hoboken University Medical Center, Christ Hospital, and Bayonne Medical Center. I just assumed that position actually the beginning of last month, after working as a sort of demi number 2 in that position for like 6 years, 5 years. There's not a lot I haven't seen in radiology. I'm one of the dinosaurs because radiologists today are being produced to really be taught in depth in 4 topics, not 10 like it used to be, which for us old heads, we don't understand that because not every group is going to be large and be able to cover all 10 bases of imaging. And if you have needs to cover all 10 bases, then you're going to be short if you only know 4 topics, obviously. Mm-hmm. And when vacations come, people have to leave. You got to cover them. So yeah, I'm a dinosaur. There's very little about radiology that I don't practice. Mm-hmm. I'm happy to answer any and all questions that come to the best of my ability. That's the short part.
All righty, thank you. Dr. Atherley, please.
Hello, can you hear me?
Yes, we can.
interventional cardiologist. I'm predominantly based at Newark Beth Israel Medical Center. But my office is my patients are pretty widespread in terms of their origin. It's a pleasure to be with you as always. I look forward to hearing the words of wisdom from Dr. Duhaney.
All right, thank you. Dr. Clark, please.
Good afternoon, Kevin Clark. I'm a surgical oncologist. I work at the Newark Beth Israel.
All right, thank you. And Dr. James Lee, welcome, Dr. Lee. It's been a while. We're glad to have you back, brother.
Yes, thank you. Glad to be back. Dr. James Lee Jr., second generation orthopedic surgeon. Offices in West Orange, New Jersey, and cover the tri-state area.
All righty. Dr. Sprott, how you doing?
I'm good. I'm Kenny Sprott, board certified pediatrician, retired. I did critical care pediatrics for 15 years and general pediatrics and administrative pediatrics.
All right, thank you. And Dr. Court, I saw him in the hospital this morning. He was working hard. Dr. Court, you have yourself on mute. Can you introduce yourself, please?
Dr. Court, James Court. My practice is located in East Orange, New Jersey. I'm an internal medicine doctor. I treat only adults.
All right, thank you very much. So our topic today is radiology. And, you know, I'll start off to say that being a critical care doc and a ICU physician, even with the nutrition that I do a lot of x-rays, a lot of CAT scans, PET scans, those type of things. And we use these studies so often in the hospital that it's just nice to know that we have somebody that can explain things. Dr. Duhaney, I want to start off with CAT scans. You know, some of my patients come in and they say they've had a screening CAT scan. You know, somebody talked to them at the hospital or somebody's office, and I had a screening chest CAT scan. Can you tell us about that and why we do that, number one? Number two, what it is and what we're looking for in a screening CAT scan?
Right now, there's two types of screening CAT scans for the chest. One is a coronary, or basically a coronary artery scoring test, which no insurer pays for. It's about $100 out of pocket per patient, but very valuable nonetheless. The other one is a screening low-dose chest CT, which is about a third the dose of a normal chest CT in an average-sized person. And it's very effective. It's extremely effective in detecting early lung cancers before they've come out the barn. Those are the two main screening chest CTs. They're both with no contrast, and there's really no prep for them whatsoever.
You mentioned the word there, contrast. What is contrast?
Yeah, so contrast agents, which I'm going to cover in the talk a little bit later, are basically tools that we use, which are for the most part intravenous, and they're designed to identify vascular function, vascular physiology in a given organ or a given area of pathological change. So, for instance, you may have a tumor in the liver, and it may be nearly invisible without contrast, but tumors typically have at least some part that is hypervascular. So, especially the aggressive ones. So intravenous contrast has been used to identify those tumors. They can also elicit normal anatomy. Coronary artery CT angiograms are one function that contrast serves when you're looking at vessels, and specifically because it's an intravascular agent, whether it's arterial or venous. We use them for hollow organs like the esophagus or the entire gastrointestinal tract, different kind of contrast, but we can use the same non-ionic contrast that we use intravenous for oral use as well. And in fact, our institution doesn't use barium for CT. They only use basically the same non-ionic contrast for IV that we use for GI studies, GI CT studies, just that they're a lower concentration of iodine than the intravenous doses are. That's only one type of contrast, though. I mean, there's gadolinium for MRI, which we're learning more and more about every year. It is a lethal agent without being bound by a chelate that obviously every contrast bottle has, but unfortunately, it doesn't completely get excreted by the kidneys as much as we would like. Every gadolinium injection is a small amount that stays in the body for a very long time. And that's why patients that have severe renal function that are on dialysis, we avoid it 100% for them. Now, when you get to nuclear medicine, it's a whole other kind of contrast. Those aren't really technically contrast agents, but those are isotopes that are used to take advantage of the physiology of a specific part of your body, whether it's the thyroid, the brain, the heart, tumors. It's designed to take advantage of the whatever biochemistry that organ system is using to identify its function or lack thereof. Air is a contrast agent, believe it or not. Water is a contrast agent. There's many contrast agents that we can use. And those are a handful. We have special gadolinium agents that are used only for liver imaging. That's about 95% of it right there.
Right. You know, and I see your hand up, Kendall. I just want to say one thing. And as far as the lung is concerned, it's very important for these screening CAT scans because the lung is unique in that it has very few pain fibers. And usually pain is the reason that, well, put it this way, pain lets us know that something bad is happening or something not right in our bodies. Unfortunately, in the lung, there are so few pain fibers that by the time we realize that the cancer is there, it's usually large and sometimes it's gone outside of the lung tissue. So it's harder to treat and the prognosis is poor. So these screening CAT scans are so important as far as the lung is concerned. I just wanted to make sure that everyone understood that if your doctor feels you are a smoker or you were exposed to something that may have caused the problem that possible cancer may be there, you should go ahead and get that screening CAT scan. As he stated, there's no contrast. It's just a basic CAT scan. It's low dose radiation. It gives us so much information. Dr. Sprott, go ahead. Your hand is up.
Yeah, Dr. Duhaney made some reference to a couple of cardiac studies, and I was just wondering if he and Trevor could discuss which is preferable in terms of visualizing the coronary blood flow, either the studies, and you talked about, I guess, a calcium study that looks for plaques. But if you and Trevor could talk about which is better or which is better indicated for the people that are thinking about their heart and maybe looking at the imaging.
Mm-hmm. And understand, you said coronary blood flow. It's the blood flow for the heart itself. Yeah, right. The blood flow that supplies oxygen to the heart itself. Go ahead, Dr. Duhaney or Dr. Atherley, whichever one wants to start.
Maybe I can mention some of the rationale for these tests. I think if we're talking about coronary blood flow, as you mentioned, I'd like the audience to be fully aware of the role of the coronary arteries and why we need to look at them specifically. The coronary arteries are tiny arteries just run on the surface of the heart and then burrow in and give branches to the muscle of the heart. Now, we are most concerned about blockages of these because of the potential very serious occurrences that may happen. Specifically, I'm talking about chest pain called angina pectoris and heart attacks called myocardial infarctions. So in an attempt to try to determine if the patient is susceptible or has had any of these dire concerns, we oftentimes use two of the tests that Dr. Duhaney mentioned. One is the coronary CT scan, and the other is just the calcium score. The calcium score is a more benign test, less harmful, and it can be used very widely for screening. What it does is identify calcification of those coronary arteries. And that's important because the methodology by which, or the process by which the coronary arteries become blocked is initially by deposition of fatty deposits, cholesterol type, into the wall of the artery, subintimal deposition, if you will. That's one of the layers of the arteries. And then these can gradually demonstrate calcification. They undergo changes. So the calcium score measures, in fact, some of the calcific changes that have occurred in these arteries. And the assumption is that this may be seen in various stages of blockage, either pre-blockage, as said, in a sense, or mild, moderate, or even severe blockage of those arteries of the heart. So this is a relatively benign test compared to some of the others that we do that can be employed fairly easily and readily as a screening test. And maybe Dr. Duhaney can help me with some of the staging of that, because we're able to quantify from the amount of calcium that is shown on these scans, we can identify the severity of the risk that the individual patient has. And if necessary, go on to further tests. I can perhaps mention a bit further about the coronary CTAs, but I welcome Dr. Duhaney's opinion about the scoring of the calcium and how we quantify the risk that a patient may have.
Well, first I'll say that I don't read those tests specifically, so I don't have as much intimate knowledge of how to stratify them specifically for you.
Okay.
However, I mean, there's a linear risk relative to a score of 0 versus the top score, which has just cakes and tons of calcium, or even soft plaque. But I think that we have to look at this in the framework of function, cardiac function, because CT is one method to look at the heart from a radiology perspective, and we can certainly do a CT angiogram. The problem is that for a CT angiogram of the coronary arteries, you have to slow the heart rate so that the CT scan can effectively capture those small arteries effectively. Motion blur will distort the lumen in every artery, and some more than others. The good thing is that if you have a brand new state-of-the-art scanner, it may not make much of a difference, because the latest CT scanners have 512 slices in one rotation. Most scanners today, most centers today will have 64 slices, but the state-of-the-art is 512. It doesn't take much time to complete a CAT scan, which is why CT may never disappear in the face of what people thought would be MRI's territory. Because
when you say slices, what does that mean?
Okay, so there's the way CT works is that it basically sends a beam of radiation, of an X-ray, through the body, and that one beam is one slice, and one turn of that one, if you think about the most rudimentary CT scanner, the first ones had one beam. That one beam would go in one rotation around the body. A detector is on the exact opposite side of the beam where the beam originated from. That detector sends information to a computer, and it uses high-level calculus, high-level math, to determine the distribution of density through the patient, through the person, or whatever you're scanning. We've gone from one detector to 512 detectors now. So each one of those beams and detectors, so each one of those beams is a single slice. Those slices now are very tiny. We can get down to a sub-millimeter level now. So when you have 512 of those, one rotation covers a huge part of the body now. So you could probably do the brain in one rotation in a 512 slice scanner. But the beauty of that type of system is that it takes less time to cover whatever territory that you're trying to image. And on the other side of the coin, if you're doing something like an angiogram, it takes less time, so that you actually provide almost like a snapshot image of that part of the body, which is critical when you're using intravenous contrast. That means that if you time the injection properly, then you get the best enhancement in the area that you're concerned about. And that's the best result that you're going to get, as long as everything else is held equal. So the patient is able to comply. There's no artifacts caused by jewelry or whatever on the patient in the area that we're imaging. And so the state-of-the-art CT is actually helping to eliminate the need for drugs to slow the heart down to do this study. Now, the question is, do you really want to see the narrowing, or do you want to see the function of what that narrowing is actually potentially causing? So we have a test called a nuclear thallium stress test, which is designed to actually monitor what happens to normal and abnormal heart tissue at rest and when there's stress on the heart. In other words, is there less uptake of this isotope at stress because the blockage is not letting the isotope come through to the cardiac tissue? That may be more valuable than getting a CT angiogram, because just because there's a stenosis does not necessarily mean that there's going to be ischemia or lack of blood flow or diminished blood flow to the heart. And the grade of stenosis doesn't always read the book. So it should. Technically and statistically, yes, a 95% stenosis is a critical stenosis. A 50% stenosis is a significant stenosis, but not nearly as significant as a 95% stenosis. But in terms of imaging, sometimes it's difficult to determine if there's a 65% or 75% stenosis. 75% stenosis is getting to the point that some kind of intervention may be necessary, either pharmacological or by interventional service or by surgery. So interventional is another type of radiology and cardiology whereby there's no surgery, but a catheter is used to open an artery through the groin or through the arm, and to provide the artery with a stent, or just typically, usually it's a stent plus angioplasty. So the angioplasty is where a balloon is put in, the balloon that's part of a catheter is inserted into the blockage and then expanded to open the blockage, typically with a stent over the balloon also, so that the blockage stays open. A metal stent that's not iron. They're usually an alloy that will not rust or move. I think that the one of the best strategies may be to do scoring to get a thumbnail of the severity of coronary artery disease and then go right to function, rather than adding intravenous contrast and potentially pharmacological methods to a patient's visit, because ultimately they may need a coronary artery angiogram, a digital subtraction angiogram in the suite by a cardiologist anyway, and that will give the most accurate. That should give the most accurate result in terms of the level of coronary artery disease,
Right.
and actually they can give therapy at that point too.
Right. What we
But I
have.
think,
Go ahead,
okay, I
Dr.
just want to mention the dilemma that we're faced in as cardiologists in determining what would be the appropriate test for any specific patient.
Right.
So we
Of
touched
course.
on the screening test, which may be done for patients for whom severe disease is not really suspected. Patients who've already had heart attacks, have had cardiac catheterizations, those are pictures of the arteries to the heart, etc., or open heart surgery. We would not necessarily go after a simple screening test, but we go further. And here the question we are often faced with is, do we do the anatomical or structural test, that is taking pictures of the coronaries, but from in a less invasive manner, pictures from the outside, as opposed to what I like to do, which is putting catheters in the body and taking pictures from the inside. But it would be prudent to first of all consider the utilization of these coronary CTAs as outlined by Dr. Duhaney. But there we see pictures of the coronary arteries, and we can recognize the severity of the blockages. If present, we can recognize and quantify the severity of the blockages with some degree of course, of questions in terms of accuracy.
Right.
And this is an actual structural test. And then there are those of us who feel, well, it may be more important to see the function. There may or may not be significant blockages based upon how they're affecting the heart, how they're affecting the patient and the patient's heart specifically. So the functional test is the stress test. We can do simple stress tests simply by exercising the patient and observing changes that occur to the patient's electrocardiogram, blood pressure, and symptoms, presence or absence of chest pain. Now, the more sophisticated one, as mentioned by Dr. Duhaney, is a nuclear stress test, where the nuclear material can allow us to discern further the functional effect of blockages and see whether or not we can document location of blockages, roughly, just locations in the heart where there's an insufficiency of the blood supply, and we can quantify the severity and decide whether or not to go further. Because I see most of these tests as merely guides to determine what to do next, as opposed to an end in all of the patient's cardiac or heart evaluation. So I use these tests and then decide, well, medication, intervention or invasive procedures, as we started to allude to, and perhaps Dr. Haney may mention later, or I may mention later, and then surgical procedures if necessary. But these initial screening tests are often very important to give us a guide as to the severity of what we're dealing with and to decide how far to go with further testing on patients.
Excellent. Let me do this. We have two physicians that have come in. Let me get them to introduce themselves. Dr. Ali, please, can you introduce yourself?
Unmute.
Hi, good afternoon. My name is Dr. Mazhar Ali. I'm a gastroenterologist at Scripps Clinic in San Diego.
All right. Thank you very much. And Dr. Patrick Anderson, how you doing, Pat?
Hi, everyone. It's always an honor to be here. Sorry, I was a little stuck at the hospital. But I'm Patrick Anderson. I'm a G1 oncologist, and I work out of Newark Beth Israel Medical Center.
All right. Thank you very much. Dr. Clark, you got your hand up, and then we'll take Dr. Lee.
All right, so there's 2 points. We don't make decisions or operate just based on films. It's always in the context of the patient and what's going on. And just to clarify, one of the questions asked, it says, if a patient has had previous heart attacks, is it important to check your calcium score? And you guys can clarify, this is a screening test. It wouldn't be used in patients who've had previous heart attacks or are symptomatic. Is that correct?
That's correct. I would find, yes, less utilization, less usefulness, of course, of such a test if we already defined that the patient has reached such a stage of severity that they've had an actual heart attack. Then the screening test to me would not be as indicative of the patient's current status. And therefore, I preferred clinical means, evaluating the patient, seeing what the patient is doing, electrocardiographic changes. And of course, you mentioned the stress test, whether plain stress test or nuclear stress test, and or coronary CTAs.
Okay.
But the simple screening calcium score would not be useful to me at that point.
Excellent. Dr. Lee, please.
Yeah, I have two questions, Dr. Haney. Thank you for being here with us today. As a clinical orthopedist in the community, oftentimes I run into the scenario where I get a patient who says, I think I hurt my shoulder, and I say, I think you need an MRI of your shoulder. And they say, well, by the way, doc, I have a pacemaker, and there may be another scenario with somebody who's a war veteran and have shrapnel retention of a bullet. Can you talk about when a patient cannot have an MRI due to previous procedures, and then moving forward when they can have an MRI, such as after knee replacement or maybe an external fixator? Can you talk about those scenarios?
Sure. There's never been, believe it or not, a coronary event that occurred because of a pacemaker. And that's probably because they've never been allowed to have one. There have been times, I guess, where it's not been discovered before the MRI was started. But having said that, there's never been an event that's been untoward for any single patient. But with a pacemaker, now there are pacemakers now that you can turn off prior to getting an MRI, and certain institutions have nurses or other staff available to do that for the patients. Some patients actually know how to do it themselves. And I guess it depends on the center. Most centers, I think, will allow the patient to turn their own device off and back on after the procedure is done. But if they don't know how to do it and there's no staff, then of course it can't be done. There's a whole list of devices that are contraindications or intermediate indications for MRI. The vast majority of aneurysm coils, if they were put in the past 2 decades, are fine. They're not made of a so-called paramagnetic metal, so they won't move. Shrapnel is an issue because we have no idea what that metal is. Bullets are comprised of various types of metals, not all of which are paramagnetic, but many of them are. So if there's enough shrapnel, this is my rule for shrapnel. If it's in the field of view that's being imaged, and it depends on what body part is being imaged, then it's a no. And basically the way an MRI works is that the strongest magnetism is in the very center of the bore. So the center meaning from all axes, the length of the bore, the center of that, the height of the bore, the center of that, and the width, the center of that, that's called the isocenter. That is the worst case scenario to have metal or even makeup, some makeup that's tattooed on the face for a brain or a face or orbits MRI can actually overheat and burn the patient. So if it's, for instance, shrapnel that's in someone's ankle and they're getting a brain MRI, I would probably approve that. Now, if it's shrapnel that's in the abdomen and we're doing a liver, no, that would be a no-go. It depends. I think the loop recorders are generally MR safe. And there's actually a website that you can look up the vast majority of medical devices as far as their safety is concerned. There's 2 books that are written by different radiologists that also list the same information that those websites have.
All right. My second question, Omar, if you would allow me.
Yeah, go ahead.
Is artificial intelligence in radiology. So in orthopedics and in surgical fields, we have robotic intervention we're able to use. And so I do robotic knee replacements. And briefly, what we do is we take a CAT scan image of the patient from the hip to the ankle. We look at the deformity in the knee, whether they're bow leg, knock-kneed. And then using the CAT scan, we're able to measure the amount of bone that we have to cut, resect, and how to contour that knee to accommodate a prosthesis. And the precision is really, really good. And the way it works is the data from the CAT scan goes into the robot. The robot then dictates how much the saw will allow you to cut. And so my question to you is, with this advent, and with robot technology, where do you see radiology with artificial intelligence?
Well, actually, I'm about to get a huge primer in that in 2 weeks. I'll be going to our national conference in Chicago, and I am anxious to see what technologies we have. I just had a dinner with a colleague of mine. Actually, he's a professor that taught me at NYU when he was a junior attending, just beginning his junior attendinghood at NYU, and then he went to Texas, and now he's back at Mount Sinai. He's the system chairman at Mount Sinai, and we talked about that briefly. And he said that, don't worry, Mike, you'll still have a job for the foreseeable future, but there's going to be less radiologists in the future. That was his immediate gut response. And they do a lot of MRI, they do a lot of AI research at most academic radiology departments, but especially at where he's at Mount Sinai. We've had AI, actually, believe it or not, in breast imaging for a very long time, and it's not been as effective as we'd like. We use it for identifying masses and calcifications, especially calcifications that are very tiny and worrisome, because those are the most worrisome in general. And those are the most common that we see in general that we have to worry about. In my experience, they've been more of a distraction than a help. And I found calcifications that they couldn't find. On the other side of the coin, I know that AI is much different than it was in the beginning in radiology, especially now that we have the computing power and the memory, the cheap memory that's available. Right now, I see it as an assistant to cross-sectional imaging. So CAT scan, MRI, actually any imaging, to be fair, to help locate masses, lesions, take measurements as a boost and make my job more ergonomic time-wise. Eventually, when it can determine, when the video chips, when the NVIDIAs of the world and the other corporations that make these AI chips can make them differentiate very fine shades of gray and determine shapes where one shade begins and another ends, then that's when I'm going to be in trouble. Because I think that as far as learning the differential diagnosis lists, I mean, those are all in books. So anything that's in a book can be put into a computer. When And the advantage that a computer is going to have that we're not going to have is they're probably going to connect that device to the HIS, which we don't have time to do.
What is HIS? For
The
people who
HIS
don't
is
know?
the hospital information systems. This is where the medical records are. And they'll be able to scan the medical records much faster than we can. And because occasionally we will go to the hospital information system to get special information about a patient that we're trying to evaluate. And with all that data, now you have a super radiologist. And yeah, you might be operating off imaging in the future. You already are in some cases through the ER. So AI is going to revolutionize radiology and other highly technical parts of medical practice very, very soon. I mean, it's not like law, because lawyers have a much worse problem than we as doctors do. But I'll be better capable to answer your question specifically in 2 weeks than I can right now.
Yeah.
All I know is that a guy that I know that's very deep into AI knows it's going to impact radiology in a major fashion. So keep your eyes open. It's going to be very interesting.
Thank you.
Dr. Sprott, you got your hand up.
Yeah, a couple of things. One is, about 6 years ago, I attended a conference in Chicago, and they talked about artificial intelligence dramatically impacting both radiology and pathology because of the ability of the detail that they're able to get down to, and as they get more and more powerful computers to diagnose things. And one of the other things that you mentioned, and again, this struck me, is the older you get, the more folks start to ask you for questions about things. And I have a friend who had a issue relative to evaluation of a pancreas that was done in 2006. And it showed something and nothing was done. And then about 5 years ago, had something to look at and saw the pancreas, saw a little mass. And it turns out that it was the same size as it was in 2006. And yet the gastroenterologist wanted to do a fine needle aspiration to look for cancer. And you can imagine what happened, which was disaster. She had a leak. She destroyed most of the organs in her belly. And had she known that that nodule was in her pancreas 8 years or 9 years ago, she wouldn't have had it done, and none of this would have happened. And so it is important that these things get linked up. And again, especially if you're looking at things and comparing them from year to year to see if they're getting larger, smaller, or staying the same, it's sort of critical to have those things kind of linked. And sometimes patients don't remember that they had something done. But
Right.
the radiologists that read the second one from the same hospital didn't review the earlier one, and therefore didn't comment on the comparison or the lack of growth from that or there, because and those things kind of happen. But
that may not be AI, actually. That may just be.
no. I went from AI to the issue of I don't want to get to the malpractice issues of not having reviewed a previous film that would have made a comparison and maybe obviated it, which is a really informed consent issue.
So this is something that is chronic in radiology, and there's always a question: how far do we absorb prior imaging when a department gets converted to digital radiology, which the vast majority of them have done that already. I will say that our hospital is very good at keeping old studies, and there may be no reports available in the system that the radiologists use to review the images, but the reports are in medical records buried in some cavern somewhere from 10, 15 years ago. So the first thing I have to say is maybe it's possible that study from 2008 may not have been available. You may know better than I that it was or wasn't, but that's a possibility, because that's not unusual in the world of, because 2008 most places were analog. So you're talking cut films that you slap onto some reading board and read the case with light instead of a LED monitor. And that's really tragic what happened to her. I mean, that's maybe the GI physician can speak to this more vocally, but a lesion that I've seen for 15 years or this known, actually, this GI practitioner didn't know that there was a prior cyst that hadn't changed in the pancreas.
Did not
Dr.
know.
Sprott did not know. Yeah, so that's truly tragic. What happened to this patient,
Mistake.
unfortunately. One thing I'm going to circle back to Dr. Lee is he asked me about joint replacements. Those are fine for most imaging, as long as it's a modern machine with modern software, because we have software now that can reduce artifact from the metal inside these prosthetic devices. And actually AI is being built into all imaging machines now to optimize image production. So it's going to be a different world soon in many ways, in front of and behind the monitor, which is amazing that we're going to get this, and it's going to come to many other parts of medicine as well. But our images should look a lot better in the future too.
So, I think we all share this concern with AI as technology is advancing, and we have to evolve in medicine, right? With AI, it's encroaching all of our specialties in a good way and not so good way as well. What I find it can be challenging in my field with AI, and especially in radiology and findings of things. When somebody comes in for abdominal pain, vague symptoms, they get a scan of their belly, and we find these incidental findings, right? And AI would pick it up, or something would pick it up. And then the question is, how far do we go? And for me as a gastroenterologist, as Dr. Sprott mentioned, do we do things like an endoscopic ultrasound with fine needle aspiration? Do we do an upper endoscopy, colonoscopy? How invasive do we do things based on what I call these incidentalomas, right? Now, to speak about that pancreatic lesion, it's very unfortunate. And, there are some newer guidelines that have come out and how we manage pancreatic cysts. And a lot of times, the best way to image the pancreas, and again, please, chime in on this as well, is I find MR imaging. And if there's like a cyst on, it's something that's branched off from one of the ductal systems within the pancreas, we just monitor it over 6 months.
Okay.
Or a year, and we see kind of any size progression before we were to do any sort of fine needle aspiration or endoscopic ultrasound. But I am worried about just these incidental findings and how far we're going to go from a practical standpoint as a clinician, and these black and white findings and the legal ramifications of that.
Right. So incidentalomas can happen anywhere: brain, heart, chest, abdomen, bones. I think that at some level, radiologist needs to assign a level of aggressivity or not to each one of them, and what their level of concern is to some degree. Having said that, for the pancreas, MRI is excellent as long as you have a compliant patient and you have an up-to-date, relatively modern MR machine, because in GI imaging for MRI, time is everything. And as you know, GI tract is a static dynamic organ. So if you breathe, if you cannot hold your breath, if you're for whatever reason you're having excessive bowel motion called peristalsis, MRI may not be superior to CT, because like I said in the beginning, CT is extremely fast now. Where patients cannot comply for the best results in MRI, they can for CT, absolutely. And sometimes we have to use that as a fallback and just trust the fact that something is appearing static on a CT that's repeated as a follow-up, that it's not aggressive. But in the best of all worlds, yes, I totally agree with you. MRI is the best for looking at pancreas lesions. The smaller that they get, size is everything in radiology. So it becomes very difficult to image below a centimeter and understand whether or not a lesion's benign or malignant, but in other words, good or bad. But in general, if it's of a certain size and MRI and the patient can comply and all the stars align properly, MRI is superior.
Excellent. Patrick, your hands up.
Hey, Dr. Dehaney. I just think, radiology is such a broad and expansive field, and it influences a lot of decision making. We decisions that we have to make, both diagnostics and therapeutics. Can you just from a historical perspective in radiation oncology, just talk a little bit how we go from using plain film to establish treatment fields in certain solid tumors, say in the pelvis, like a cervix cancer, to where we are now using IMRT, where we do CAT scans in real time and integrate that into a therapeutic modality that treats patients more accurately. And, unfortunately, in the case Dr. Spratt talks about, is an imaging that led to an intervention versus an imaging that enhances and reduces the risk of treatment.
Okay, so you're talking about an arm of radiology that is typically under the administration of most radiology departments, but is technically a completely separate department unto itself. You're talking about radiation oncology. And so you're talking about a department that has a CT scanner and some other X-ray equipment, and then they have separate equipment that's designed to radiate tumors with great precision. And I mean, the two are vastly different because one is a diagnostic modality, the other one is a treatment modality, the other one is a therapeutic modality, like you said. But the CT that's used for radiation oncology for treatment as a pre-treatment planning device is not, you don't have to have nearly the amount of sophistication, because as long as you can find the best and safest windows for radiation therapy. In other words, the pathway to send the radiation is key, is what the radiation oncologist is looking for with a preliminary CT. As long as you can get that pathway determined, and you can make the calculations of where the most optimal, what the most optimal path of moving the radiation through the body so that it gets concentrated in the tumor and not the surrounding tissue, then that's all you need for therapy. For diagnosis, you need a better system and contrast agents. You don't need contrast agents for radiation planning prior. I mean, at the point of therapy, you do for diagnosis. Some of the smartest people I've met are radiation oncologists. I mean, they know a lot of the oncology, the medical oncology protocols to a large degree, as well as the oncologists themselves. I've been in many tumor boards where they imparted a great deal of knowledge to everyone in the room. I just can't see myself doing that, but every part of medicine has its own personalities and gravitas for each individual doctor. I don't know if I've covered your question that well, because it's not something that I do, but
Yeah.
I know that there's I mean, and they're not the only ones that do that. I mean, you have, for prostate cancer, for instance,
right,
you have urologists that place seeds in the prostate gland itself that are radioactive. These are metal seeds that have radioactivity built in. And that can be done in the liver. That can be done in other organs too. Interventional radiologists do what's called yttrium therapy for primary liver cancers. And they introduce those by CT guidance into the center of liver masses. So there's many different types of radiation oncology, some of which aren't done by radiation oncologists.
All right, thank you. Dr. Court.
Good.
Question, and then we'll go to Dr. Spratt.
I think the doctor may have covered this before, but my interest was in terms of patients who need MRI scans and a pacemaker inserted. Does it depend on how long the pacemaker was inserted? What type of pacemaker? Can you give us some guidelines as to how should we approach this?
Sure. I'll just say roughly in the past, probably 10 years or so, that these radiation safe pacemaker and defibrillator devices have been installed. There's a measure of safety that the time frame imparts to any given situation. So within, say, 10 to 12 years, and especially if the patient knows, if the patient doesn't know whether their device is radiation safe or not, then we won't do the MRI. They have to know, or they have to have some kind of documentation. If they're not sure, we have to find a way to get that information from them. If the device is not known to be radiation safe, we will not do it. MR safe, we will not do it. Even if it is MR safe, it has to be deactivated also. So that's a second hoop that has to be jumped through.
Okay. Excellent. Dr. Sprott.
Yeah, Dr. Duhaney, just, again, a friend who I'm helping out. And James, you can listen to this too. A shoulder replacement, and it dislocated, possibly related to an infection. And he went to Emory, and Emory did a review, and they did a CT scan. And on the CT scan, they talked about that. But then they said he's got some pulmonary nodules in the upper parts of his lung. He's got cardiomegaly. He's got some calcifications of his coronary artery, and he's possibly got a descending aortic aneurysm. And so he's, got this report from the orthopedic surgeon in Atlanta. He's in Birmingham, and none of the doctors know about all of these things that the radiologist has discovered on this CT scan that was really looking at this shoulder. How do you sort of assure that either the patient or the doctors that need to know this knowledge can address it? I told him he needed to see his primary to go see, someone, because they think that maybe the lung nodules were nothing, but certainly he's need a cardiologist to deal with possible coronary artery issues and this aneurysm. But as a radiologist, how do you go about trying to assure that the right doctors, other than the ordering doctor, does the job? Because, not to knock orthopedics, but he may not know the other doctors in Birmingham that the patient needs to go to.
Okay, so as a radiologist, this is a chronic issue, and it's an important issue that every radiologist has to address. Typically, I'll tell you what I do when I have taught other radiologists they need to do. It doesn't really matter to me what the specialty is of the referring physician. It's their job to act on the results of any given examination. So, and I had a case where there was a gentleman who came to the hospital with I think he had a cough, and he ended up having a small mass. And later, this gentleman, he didn't get therapy, for whatever reason. He got some orthopedic surgery done, but there was a chest X-ray done as a preoperative study before his surgery that showed the mass and that it was still there and was not addressed. This became a lawsuit because he ended up having widespread metastatic lung cancer, ultimately because that was not addressed. And an anesthesiologist was brought into it. The orthopedic surgeon was brought into it. ER physician was brought into it. I inform the referring physician for the test that I see the potential malignancy or problem when I see it. And then it's up to them to refer their patient to whomever for the next therapy level. Technically, radiologists are required to speak to the referring physician, not a PA, not a nurse practitioner that happens to be in the office, not a secretary. Oh, I've confirmed that the fax report was received in the primary physician. That's not good enough by law. You're still liable if you haven't communicated by telephone or some other means and confirm that communication with some, whether it's a text or whatever. In your technically, you're supposed to call the physician or text and then put it in your report. Then our job is considered completed. Now, in this world where all medical information is becoming made available to patients on a portal, they're not responsible for knowing their information 100%, but they are best served when they do know their information 100%. So I would encourage every one of you to let your patients know when their results are available, to know their results and check their results as well, because they typically are their own best advocate. Not always, but much of the time. So that's, I guess, a double way to answer your question.
It's just that a lot of folks, don't have the capability of getting through that medical jargon about all of this stuff, glenoid process,
Right.
this angulation and this and that. It's very complicated, and
that is complicated. But when you see the word tumor in your report, that's pretty translatable. Now, I'm not saying that everything that's in a report is in layman's words. It's not. It's not. But to the extent that they can get their own information and have their primary caregiver explain that information to them, they're best served to have that information, especially if they're going to go to different doctors in different systems. Because what happened to that patient that had the pancreas cyst that was aspirated? If that was a whole other institution that the prior CT or imaging study was done, and that wasn't retrieved for comparison or whatever, then that could easily have been repeated in another patient and have the same horrible result. That's another thing that's a problem, is that there's so many proprietary, what are called DICOM or radiology software systems that are competing with each other. It should be one system. It should be one system that is non-proprietary, that you get a CD and you pop it in your computer or whatever, or you get an email and you go to some web address to look at images, that they come up instantaneously. The problem is that there's so many different methods that these imaging corporations have encoded their information, that they're not easily retrieved and not easily compared. It's a huge problem.
Yeah. Patrick, I see you have your hand up. Do me a favor, just hang on just for a minute. We're going to break for our halftime introductions and stuff like that. I'm just so happy that everybody's out there listening to us, and please continue to write your questions in. We will get some questions right after Patrick. We're going to do questions as well, Patrick, okay? What I'd like to do is first reintroduce. I'd like for each and every one of us to reintroduce ourselves, because people joined after we had our initial introduction. Patrick, can you start off, please? You're muted, Pat.
Yes, sorry. I'm Patrick Anderson. I'm a GYN oncologist. I work at Newark Bethesda Medical Center, and I've been just so honored to be part of this process over the years. Dr. Doheny, thanks for being here. You're imparting a lot of knowledge and will obviously help us figure out how to deal with some of the questions that we get from patients now that they have portals and they get results that need to be explained.
Yes, true. Dr. Doheny, please.
Hi, happy to be here. And it's the first, and I actually have a gentleman that I think would be a fabulous addition, who's actually from East Orange, but he practices in the Washington, D.C. area now. I don't know if you guys are aware, Dr. Leslie Kingsley. He's a pulmonologist and critical care physician in Washington, D.C. Right. At any rate, I'm a radiologist, diagnostic radiologist, neuroradiologist under specialty training. I work in northern New Jersey in a health care system called CarePoint Healthcare in Hudson County, New Jersey.
All right, thank you. Dr. Clark.
Hey, good afternoon, Dr. Clark. I'm a surgical oncologist. I work in North Bethesda.
Dr. Court.
Good afternoon. My name is Dr. Court. I'm an internist. I practice in East Orange, New Jersey.
Right. Dr. Ali.
Hi, good afternoon. My name is Mazhar Ali. I'm a gastroenterologist in San Diego, California.
Right. Dr. Lee.
Hi, Dr. James Lee Jr., second generation orthopedic surgeon, West Orange, New Jersey.
All righty. And Dr. Sprott.
Dr. Kendall Sprott, board certified pediatrician, did critical care pediatrics, general pediatrics.
All righty. And Dr. Atherley.
My name is Trevor Atherley. I'm an interventional cardiologist. I practice primarily at Newark Bethesda Medical Center. Thank you.
And as usual, I always forget to introduce myself. I'm Dr. Omar Bey, pulmonary critical care and the subspecialty in nutrition. All righty. Second thing I would like to say is that our webinar, as I stated before, is every second Saturday at 1 o'clock. Please let family and friends and church members know. It takes a village to make something like this successful. All righty. And please come and ask your medical questions. Important thing that I can say today is please do not change any aspect of your medical care until you consult your physician. Only your doctor, only your private healthcare provider can truly take care of you appropriately. All right. And I would like to thank OBHealthy for allowing us to bring this platform to you. And also, if you want to see our prior webinars, please go to OBHealthy, hit the YouTube sign, and all of our prior webinars are there. A lot of information, great information about health as far as, and I like to think of it as far as people of African descent, we all need this and to be educated about our health. All righty. What I'd like to do is, Patrick, go ahead with your hand up and then we'll get to some questions.
Yes, Dr. Doheny. With respect to what's reported to patients and their access to results on a portal, we often get patients call and said, I'm confused. They said my mammogram is normal, but at the bottom, there's this thing that talks about dense breasts and abnormalities. Does this apply to me? Can you comment on that and why that disclaimer is there on the mammogram report?
Sure, absolutely. And it's something that I do on a regular basis. Okay, so breast parenchyma, breast tissue, the tissue that makes up a breast, is typically made of two components, two basic components. The actual tissue that used to make or still makes milk, which is called parenchyma, and there's fat. In imaging, especially when it comes to calcifications, trying to identify calcifications, which many, if not most women have, after a certain time in age, and that age is not necessarily in the 80s, 70s, that can be in the 20s and 30s too. But when we're looking at a mammogram, we're looking for two things. We're looking for calcifications, particularly small calcifications, and we're looking for a mass. The less milk producing tissue that is still remaining in the breast, which typically happens in older women, particularly postmenopausal women, but not always. I've seen 80-year-old women with dense breasts. That's supposedly related to fibrosis. The more dense a breast is, the harder it is to find the tumors and calcifications, but typically tumors. And so if we don't see anything that's suspicious, but there's dense breasts, typically there's two categories of dense breasts, very dense breasts and just dense breasts, then we recommend ultrasound as an adjunctive screening or an additive, an extra screening tool, because the density of the breast doesn't necessarily make a difference with ultrasound. Sound can penetrate tissue better than x-rays can in many results, especially because breast imaging involves a very small dose of radiation, very, very small doses. And we're not able to increase the dose to try to find more tumors. It's just not practical and it's not safe. So there's two kinds of breast imaging that are still done on a screening basis as far as mammograms are concerned. Two-dimensional, which is what had been done for decades. And then there's three-dimensional, what's called tomomammography, where you're actually doing like a small CAT scan on each breast. And that's the state of the art. The three-dimensional breast imaging, three-dimensional mammography is what's recommended. If you can find a tomomammogram center, that's where you should have your mammogram done, because that's the best chance for identifying tumors in dense breasts in particular. Fatty breast is not nearly as helpful. I mean, I think that it's actually not helpful for those breasts. And that's why in some reports, you're going to see the language that there's dense breast parenchyma, and a discussion should be made with the patient as to the benefits of breast ultrasound screening for those specific patients. It doesn't, there's designations that we're by law required to put at the end of a mammogram. And they range from BI-RADS 0 to BI-RADS 6. Those are grades of follow-up in breast imaging. And anything that's less than a 3 doesn't require any further imaging technically. But if you have dense breasts, you should still consider breast ultrasound.
Thank you.
Real quick. I encountered the same thing in terms of what Dr. Anderson just said. That disclaimer that's put at the bottom of the report. What I do, I just send them to Dr. Clark.
Send
Because
them where, Dr. Court?
I just send the patients to Kevin, Dr. Clark, because of that disclaimer. It's your mammogram is known, but then that disclaimer, that Patrick referenced to, at the
So
bottom.
Kevin, do you thank him when he gives you those kind of referrals?
Yeah,
Most times, yes.
just to cover myself, because the patients want to know it's normal. Then there's that disclaimer.
I think it involves a discussion. And I think the point we made earlier, you don't necessarily act on just the results of a film. It depends on the context of what's going on with the patient. But certainly, patients receiving their results, it's a good thing. The bad part about it is that if they receive the results before you're able to discuss it with them, then that could be very confusing sometimes. Very anxiety-provoking situation because they can't really interpret what that means. And certainly, a mammogram report is a very intimidating report sometimes because there's a lot of words, there's a lot of things to look at. And the bottom line, sometimes it comes down to you just need a follow-up image in a year, but that has to be discussed and interpreted in the right context.
True. Dr. Sprott.
Yeah, Dr. Duhaney, you mentioned you sort of specialized in neuroradiology, and
Right.
I did critical care pediatrics, and we had a lot of premature babies that had bleeds, and they would have CT scans, and it seemed to me that some of these newborns might have had 12 CT scans before their second year of life.
Right.
And I was just wondering whether or not there's a way that you can sort of quantify the amount of radiation that some of these kids get, because the radiation itself can cause cancer or be associated with cancer. Is there a way that, or you sort of keep track about the amount of radiation that someone might receive because they've had certain kind of injuries in the past?
That's a great question, and it's a huge problem, not just for neonates and for newborns, but for adults. Like think about kidney stone patients. They get a lot of scans. They get a ton of scans. Some of them, I've seen one patient that had like 9 or 10 scans in the space of like less than 2 years, and which is a joke, really. I don't know why anyone would need that many scans, but the patients are out there that have these scans, and it's unfortunate that imaging has a huge role in medicine. Sometimes I think it has a larger role than it should, depending on the physician. But having said that, we are required to put doses in every CT scan report. So you should see some number next to the unit milligray that quantifies the radiation dose that was absorbed by the patient. For pediatric cases, we actually adjust CT scanners to minimize the doses. Those images aren't as good as they could be because of that, but they're diagnostic. I don't think there's a repository in any one hospital that quantifies the total cumulative dose for any one patient at this moment. In the future, we probably will, but as of right now, we don't, because some patients really do require a lot of imaging, and those typically are patients like oncology patients that, or surgical patients that are having a rough course, and there's really no way to get around that dose situation. There's been no study, and I don't know if there ever will be, but there's been no study so far that I'm aware of that's shown the impact of radiation on any one class of patients over a lifetime. Certainly, there are studies done on the Nagasaki and Hiroshima victims, which forms the basis of any radiology department's understanding of radiation doses. And the vast majority of patients are safe, regardless of the number of X-ray tests they've had. That includes just regular X-rays and CAT scans, which involve radiation, and then nuclear medicine patients also get radiation. MRI and ultrasound are not ionizing radiation, which is dangerous radiation.
Back in the early days when I was a pediatric resident, and leukemia was uniformly fatal.
Right.
As they started to work and discover ways to treat, they found that a lot of the kids would have leukemia cross the blood-brain barrier. And in order to take care of them, they would get radiation. And they found that if they received a certain amount of radiation to sort of eliminate the leukemia, a large, well, I'd say a significant number of them started to develop brain cancers.
Right.
And so they then were able to reduce the amount of radiation to take care of the leukemia and prevent the development of brain cancers. But that was something that they figured out through these collaborative studies.
And those are for radiation therapy. That's not for general diagnostic radiation.
No, I understand, but I'm just saying that both the radiation therapy and the diagnostic radiation, for X-rays is quantifiable.
It absolutely is.
Yeah. Let's do this. Let's get to some questions because we haven't done any, and there are a couple piling up. Let me do the first one. I've had an on and off lightheadedness, and cholesterol is being monitored by my cardiologist. LDL went down to 59 after statins. Question is, I've done a neck MRI, no stenosis found. MRI of the brain denied by insurance. What else should I consider? All right, so on and off dizziness or lightheadedness and trying to figure out why. Other studies?
Well, maybe we can start by looking at some of the causes of dizziness. They're multifactorial. And from my viewpoint, I look at structural and electrical abnormalities to begin with. And it might be fairly easy to do a monitor of the electrical system of the heart, an ambulatory outpatient EKG monitor device, sometimes called a Holter monitor. We have a Zeo patch. You can record for 24 hours. You can record for up to 2 weeks. And if necessary, we can record for even longer periods of time by implanting a loop recorder. So if we are concerned about arrhythmias or irregular heartbeats, then that's one way to try to detect any abnormal electrical activity. Simple things like looking for postural hypotension. By that, I mean a fall in the blood pressure when the patient assumes a standing position. So that can be easily measured in the doctor's office or in outpatient or hospital settings. However, I would say that a lot of the times we are unable to find an actual cause for dizziness. We look at structural causes, look at valvular heart disease, look at disease of the heart muscle, for example. Sometimes these may be associated with dizziness, but many times it's difficult to specifically define a cause for the dizziness. Now, this patient also mentioned being under the care of a neurologist, and obviously there are going to be a large number of neurological tests that can be done. What I would say about the cholesterol level is that the patient seems to have achieved a good level of cholesterol. To get down below 70 is our aim for patients who have, or it has been our aim, for patients who have defined coronary artery disease, that is blockage of the arteries, defined by heart attacks or by catheterization reports, etc. Here he's got down below that. Our new standards lower the cholesterol requirements even to even lower levels in patients who define coronary artery disease. But I'm not going to get into those specifics. What I will say is that in general, an LDL cholesterol of 59 sounds like a very good level.
Mm-hmm.
Yeah. And sometimes people have issues related to diabetes, and they might have low blood sugar that could also make them lightheaded. So you need to sort of get a sense as to what her dietary intake is or isn't when she becomes lightheaded.
Right. And she stated, and it was stated that she had a cardiologist following, but not a neurologist. So I would say definitely a neuro workup would be appropriate at this time.
Absolutely.
Okay. Second question. While survival, and I'm not sure, let me read the question and we'll see if we can answer it. While survival rates for many types of cancers are well above 90%, while outcome for other cancers, i.e. pancreatic, are improving at a much slower rate, despite intensive efforts. So they didn't personally ask the question, they kind of made a statement. But can we talk, Kevin, about, why some cancers are responsive, others we have much more work to do?
Sure. One of the things I wouldn't use survival rate to necessarily look at progress, because it can artificially be high if some features are changed. For instance, if more patients are living longer, or if we include more benign or earlier lesions, it may artificially seem that the cancer is actually improving when we haven't actually changed it. So one of the things we look at is actually mortality. So what's the chance of you surviving with a new diagnosis of cancer? And I think what the improvements in terms of the numbers are based on two things. So our ability to screen for it and detect it at an early stage where we can do something about it. And the other thing is our effective therapy. For pancreatic cancer, unfortunately, we don't really have a good screening modality now. And Dr. Dehaney can talk to this a little bit. If we can, our tests are pretty sensitive up to a point, but we're talking about picking things up at a preclinical stage where we can affect the natural history of it. So doing surgery on a lesion that's less than a centimeter or a centimeter, that's just not something that we've been able to do with pancreatic cancer. We have made improvements with some of the treatments. So surgically, I think we're almost maxed out in terms of what we're doing. We're doing pretty radical operations, and the survival rates are pretty good with acceptable complication rates. So I think we've pretty much done I shouldn't say as much as we can, but we're towards the limit to what we can do from a surgical standpoint. The real issue is improving on systemic therapy and or radiation. So radiation is almost complementary to surgery. Our systemic therapy, as compared to other cancers like breast cancer or colon cancer, is not effective for pancreatic cancer. That's really the limitation. It's late diagnosis and not really have an effective therapy. And that puts, if you look at the data, our survival, typically look at patients that we quote 5-year survival rates. And the 5-year survival rates for pancreatic cancer overall is about 10 to 15%. And that really hasn't changed over the last probably 30, 40 years. There are snippets of areas where we have improved, identifying some high-risk patients, and screening those family members, especially if they have a family history of BRCA and some of the other mutations that we know put you at risk. But overall, it hasn't been as great as, say, for breast cancer, where it's not really, I wouldn't say 90%, it depends on the stage, but certainly that's one of the better cancers, so to speak, to have.
So Kevin, could you talk a little bit about the differences between cancers that are in the blood versus soft tissue versus solid tumors?
So cancers in the blood, the liquid tumors, so the leukemias, which I don't treat at all, the myelomas, the myelodysplastic cancers, those have to do with the blood components. So the white cells, to some degree, the red cells, and they tend to be related to the bone marrow. They're primarily seen in pediatrics. So that's the main cancer that we see in pediatrics, as opposed to solid tumors like colon cancer, breast cancer, prostate cancer that we see in adults. So the liquid cancer, so to speak, like the leukemias, lymphomas, are more, again, related to the blood and immune component. It's the major cancer in pediatrics as compared to adults, where the major cancer is going to be the solid tumors as opposed to the liquid tumors.
We have another question. Let's get Dr. Ali. This one is directed directly to you, man. Dr. Ali and other GIs on the panel, I've had an upper endoscopy which found an ulcer caused by H. pylori. Took medications, also benign polyps from colonoscopy removed, still bloated and feeling full. What other tests should I request to understand what's going on?
So I think there's two separate findings here, right? So let's talk about the ulcer and H. pylori. So H. pylori is an infection. It's actually the most common infection, chronic infection in humans. We can see prevalence rates as up as high as 50% in people. Now, not everybody who gets H. pylori infection, however, develops symptoms. And the symptoms that people can develop with H. pylori relate to inflammation within the stomach. And that can increase like risks of things like ulcers or what we call gastritis. And the other is increased risk of gastric cancers, right? So the World Health Organization has deemed H. pylori an organism that can increase the risk of gastric cancer. And how people develop it, we're not quite sure. We think that it could be from something that's eaten. A lot of times the infection rates in countries with higher prevalence, you get it as children and you just kind of have it, and you develop mechanisms to keep your stomach protected. However, when we have patients who have symptoms like abdominal pain, bloating, discomfort, then an upper endoscopy usually is warranted, or we evaluate to check for H. pylori. And in this case, it sounds like an ulcer was found. So the way we would treat that is with antibiotics. And the antibiotics that we would typically give is not just, unfortunately, one antibiotic and that's it. H. pylori lives in a very unique environment because it lives in the stomach and it likes highly acidic environments itself with a low pH. So the way we would typically treat it is with 2 antibiotics and an antacid medication. Eradication rates can vary depending on what part of the country you're in or what part of the world you're in. And sometimes it may require a second round of therapy due to antibiotic resistances. Unfortunately, when people take a lot of different antibiotics for reasons, we could develop resistance to it and it may require another round. But if usually in these scenarios, we would want to check for eradication of H. pylori after treatment. And usually that's 2 weeks after completion of therapy. And it could be checked by a stool study called an H. pylori stool antigen or a nuclear medicine breath test. And in other cases, particularly, and I may want to suggest in this case, if there was an ulcer found and there's still symptoms, sometimes we could repeat the upper endoscopy to see if the ulcer is healed. And oftentimes we would do that because of that that increased risk of cancer. Even though it's a low risk, it's still there. We go in, we check we look at that ulcer, we rebiopsy that site to make sure the H. pylori is eradicated. It can be the cause of bloating. Bloating is a very vague symptom, though, and a lot of other things can cause bloating as well. Other examples, reflux. It could be a manifestation of reflux. It could be aerophagia, just swallowing a lot of air. People who may have diabetes, there's something called gastroparesis or slow stomach emptying, and that can cause bloating, fullness. And ways that you could check for that is something called a gastric emptying study. And then, the other and the most common cause that I see of bloating is usually from things that we eat. And certain foods are not digesting the right way, and it can create a lot of gas production, and it just kind of gets trapped in the small bowel, and it can make people feel bloated or gassy. So what I usually would recommend is avoiding the foods that can trigger that. And there's something called fermentable foods. So things like broccoli, cauliflower, onions, these could be culprit foods as well. And it would just be a matter of seeing what you're eating and trying to see if you can avoid certain things that can cause those symptoms. Second question is polyps. Colon polyps are very common and we find them when we do routine colon cancer screening exams with the colonoscopy. We find our detection rates can be more than 50%. So it's not uncommon to find a polyp. You could have the healthiest lifestyle, no family history, and you can have a polyp. Not every polyp turns into a cancer. The risk of it turning into a cancer is actually pretty low. But whenever we see a polyp, we remove it, send it to pathology. And based on the pathology, if there's something that shows any precancerous, not cancerous, but precancerous features in that pathology specimen, then it may warrant us to say, well, you may need another colonoscopy in 5 years or 7 years or somewhere earlier than the 10-year mark.
Excellent. All righty. Thank you very much. Well done. Very well done. The next one is, what is Dr. Haney's opinion? This is HDR. I guess that's high radiation to the prostate.
I'm sorry, what was the question?
It is, what is Dr. Duhaney's opinion? HDR to the prostate. I guess it's high dose radiation, maybe?
Oh, are they really referring to what is it
I don't
again?
know if
A radiation oncology technique, CyberKnife?
maybe,
I
I'm not sure.
presume-
This is what it states. So
Probably.
This
Yeah, it
is okay.
sounds-
That's what it sounds like.
Yeah, so I my opinion is, and I've thought about this in case I have to make a decision one day. I think most urologists, and maybe there's a built-in bias, prefer robotic prostatectomy for treating prostate cancer. I don't know that some of the complications, for instance, impotence, are any less with CyberKnife, but it certainly is a more precise way at treating prostate cancer than most operative procedures that I'm aware of, because there are less complications. But as far as being effective, I don't know that it's any more effective than any surgical technique.
Yeah,
In terms of mortality.
I think the tenets of radiation oncology, I guess to understand this question, we have to define HDR, high dose radiation, versus LDR, low dose radiation, which requires implanting a device and delivering a certain amount of radiation over several days, which takes a longer time to deliver the treatment, which implies that if you do a higher dose radiation, you get a quicker response, because then you're giving a similar dose radiation over a shorter period of time. So for example, in cervical cancer, we used to place these SIAD templates on tandems, and you would have the patient in a room, and the radiation seeds per se would be implanted over several days, and that patient would stay in bed for over that period of time, versus now where you put in a cervical sleeve and you put a tandem and couple stats in, and you deliver a higher dose rate over a shorter period of time. And what's been shown is that if you deliver the same dose of radiation over a shorter period of time, the treatment becomes more effective from a disease perspective. What I cannot speak to is what Dr. Duhaney suggests, that is the complication rates relative to other treatment modalities. So I think that's what's implied in this question. But to Dr. Duhaney's point, there are several ways to deliver radiation through different types, right? There's IMRT, there is proton therapy, there's CyberKnife, of which I'm not going to advertise as though I know I'm an expert in any of this, but this requires a consultation with a radiation oncologist who really understand not just the different modalities, but the delivery of these treatments.
But the key is mortality. Which one provides the greatest or the lowest mortality rate? And if that, to me, should be, I mean, yes, complications are important, but ultimately survival is the most important, right? So that, to me, should be the forefront of
I think
the decision process.
I think
If there's any benefit.
historically, sorry to cut you. I think historically for the same stage disease, radiation and surgery, from a mortality standpoint and overall survival, have been somewhat equivalent. And it's really been the difference between the complications rate. So the urinary complications, the sexual complications, those issues, which have gotten better with surgery. Once they went from, clearly open prostatectomy was not a great operation, to robotic prostatectomy with nerve sparing. So I think it's really part of it is complications. What are the trade-offs of complications? There's certainly complications from radiation too. But the overall survival, I think, and again, I don't treat prostate cancer, but I think has been somewhat equivalent. And that's why you're able to choose either or it is an option.
Excellent, excellent. Thank you. There's a question that came up about I was cleared for a knee for a knee surgery in June. What happened between June and October that caused me to have an emergency surgery and receive a pacemaker? I took meloxicam for 10 days in September, started feeling short of breath, and now here I am. Life changed. So this is a little unclear, but Dr. Lee, can you help us out as far as, are you familiar with naloxone at all?
I am. Certainly, it's an anti-inflammatory. It's a non-steroidal anti-inflammatory. Comes in 2 doses, 7.5 and 15 milligrams. It's typically once a day. It's not an uncommon practice medication for patients that have arthritis. Now, in this particular patient, it sounds as if she was having an elective surgery and it was planned, and then maybe during the screening process, you know, she had an EKG or she had some abnormality on the study, which I have seen plenty of times in my practice. She may be attributing to meloxicam, but I can't say that I have seen that. You know, historically, you had the Vioxx situation years ago with cardiac issues, which, you know, was a little bit before my time. But in this particular case, I don't know of a study that relates to meloxicam. You know, I do know some anti-inflammatories can have issues where they can affect the kidneys, but not necessarily cardiac. And I would certainly want to know an objective clinical study she had to diagnose whatever issue, you know, she needed intervention for. She needed a pacemaker, then I'd imagine there was some cardiac test that showed that she needed that, as opposed to maybe the meloxicam inducing something like that. I don't want to say no, but I would say it's a little unusual.
Yeah.
The need for a pacemaker is unclear here because there are many indications, many reasons to place a pacemaker. Just for the general audience, again, I'd like them to understand that a pacemaker is an electrical device to be placed to allow to improve the rate of the heart, not the strength, but the rate predominantly. So we have to assume that something happened to diminish the rate of this patient's heart, or in unusual circumstances, something that happened to her electrocardiogram or to her clinical status or symptoms that showed that she would either permanently or intermittently have such a slow heart rate that she would require to be protected with a pacemaker. Now, the heart is paced naturally by impulses which generated from the upper areas called the sinus node, passing through the AV node or the middle area down to the lower chambers, the ventricles. So in order to have proper synchronization of the heartbeat, electrical impulses are required to transmit electrical activity from the top to the bottom areas of the heart. Clearly, something went wrong with this, either a malfunction of the upper area of generation of the electrical device, electrical activity, or something wrong with the conduction from the upper areas to the lower areas. Nonetheless, if the consequence appeared to be a slow heart rate, then one can understand the need for a pacemaker. What we do not understand from the information given is why this occurred. We don't have a description of the EKG. The use of meloxicam, which he said started in September, and it doesn't appear as though that had any temporal relationship to the use of the pacemaker. So we need a little bit more information, but hopefully the pacemaker that is implanted will take care of the problem that was determined by her doctors to exist to require such.
And from a pulmonary standpoint, I'm not familiar with meloxicam causing any shortness of breath related to the lung. I was trying to think if that medication had any side effects that would cause shortness of breath, but I'm not familiar with the medication that much, but I haven't had any patients come through or any concerns in the past of pulmonary problems with that particular medication, because her problem now is shortness of breath. Next question. Hold on, just moved on me. Is info as to diagnostic radiation exposure from x-rays you have shared also applicable to dental x-rays? Alrighty. Dr. Dehaney, dental x-rays have the same, I would say, exposure rates or amounts as normal x-ray?
No, I think they're different, but the key is the volume that you're imaging. Okay, so size counts, small versus large. and what type of tissue are you imaging? Very low dose, not very low, but the lowest, among the lowest doses we provide for radiation-based procedures like x-rays would be chest x-rays, because we're basically imaging air. And because of that, all of the x-rays, not all of them, most of them go straight through and never make any dose absorption in your body. So if we do an x-ray of your chest and then do an x-ray of your belly, because there's more water in the belly than in the chest, and it's a more dense medium, that radiation gets absorbed greater in your abdomen than your chest. So the dose is greater, even if you give the same exposure, which we typically won't, because the machine can tell when it needs to stop delivering radiation to get an adequate picture. But even if you told the machine, no, give the same dose for the chest as the belly, there's more absorption going into the belly because there's water. So for dentistry, you typically need higher doses in a small volume. So the absorption is probably greater in the mandible and the maxilla, which are the two bones that form the roof, and the maxilla is the roof of your mouth. The mandible is the lower part of your mouth that allows you to speak, basically, and chew. Though you're going through bone and you're going through teeth, which are the densest parts of your body. So to answer your question, yes, there's significant radiation that's going through any dentist's office. And that's it depended on how often. Some of us need more dental work than others. So the patients that need more dental work, they're going to have more exposure. Having said that, I'm not familiar with anyone developing a cancer based on dental exposure.
I think the issue is shielding the thyroid.
Right, shielding.
So I'm sorry, shielding.
Yes.
Actually, yes, shielding thyroid is important, and that should be done. The thyroid is a very sensitive organ. But having said that, we tried creating shielding devices for breasts for CAT scan, and actually that actually kept more radiation in the body than we'd like. So we stopped doing that. So shielding is not always beneficial. In the case of the thyroid gland, it is beneficial. For the chest, it just can't be done because the thoracic inlet has to be imaged with the chest, and the thyroid is in that same general vicinity. Is a chest X-ray going to harm your thyroid gland? No.
Excellent. Dr. Anderson, go ahead.
Yes, Dr. Duhaney. For guys like Dr. Clark, myself, who live in the cancer world, our radiology colleagues have two main importance. One is diagnostics. So it's not unusual, before even Kevin and I collaborate on a big operation, we do what we call radiology rounds.
Right.
I go down, I review all the images. But more importantly, from a screening perspective, there are those diseases that we don't really have good screening modalities for. When you talk about specificity, sensitivity, prevalence, and those kind of things. Ovarian cancer. Can you speak to your diagnostic ability to screen, diagnose with a certain degree of certainty or lack thereof for ovarian cancer?
Okay, so when we're imaging for ovarian cancer, size count. So typically, your classic presentation of a patient that may have an ovarian issue that may be malignant is a patient that has an increasing waistline that is unexplained. They're not gaining weight, but their waistline is increasing, for instance. That may be because of a large cyst that's in the pelvis. Typically, we don't worry about what are called simple cysts. In other words, cysts that have just the walls and no septation, no inner parts, no nodules inside, or inner walls that connect one side to another, or have irregular walls that have like strange surfaces inside. But when it gets to the point that they reach a large size, no matter what type of cyst it is, then we tend to follow those up. And that cutoff tends to be 5 centimeters is very worrisome, but for me, it's closer to 3. That's arbitrary, but it's a safety mechanism that I've developed over time. But 5 centimeters is the academic cutoff, technically, that something is worrisome. Some cyst in the pelvis that might be in the ovary is worrisome. And the next step above pelvic ultrasound is MRI. Now, before I go to MRI, pelvic ultrasound is 2 varieties. through the abdomen or above the pelvis called transabdominal ultrasonography, which involves taking a device called a transducer that has a curved shape at the end that touches the skin, and it's used to send sound into the pelvis, and that sound comes back. Now that sound is exactly what I said. It's sound. It's not radiation. It's not magnetism. It's just sound that you can barely hear. If you put a transducer to your ear, you may hear something, but on the body part that's being imaged, you're not going to hear it. It sends sound back, and the way the sound comes back to the transducer is how the study gets interpreted or developed by a computer.
The sound waves.
The sound waves are sent into the body, and some of them bounce back. Most of them do bounce back, not all of them. And depending on what kind of tissue that sound has gone through, they're coming back at different velocities. And that's how the tissue can be differentiated from one type to another. And that's why we get an image. The same thing is done in oil exploration. They use a shotgun and they shoot a pulse into the ground. And based on the reverberations that come back from that shotgun, you get images in a machine that's similar, that's basically a sophisticated ultrasound machine or a different kind of ultrasound machine. At any rate, to answer your question, the workhorses of pelvic imaging are ultrasound, transabdominal, transvaginal, which means putting a probe inside the vagina, which can give you exquisite detail of the ovaries, the uterus, and cervix, and endometrium. And if we have questions beyond that level, which is basically screening and a follow-up tool, then we do CT or MRI. Now, when it comes to what are called adnexal, or the tissue that's right next to the uterus on either side, adnexal masses, if they're not of a certain size, they're not going to be that well evaluated by CAT scan, and contrast CT included. So MRI is the next step to look at those, and those give us the best detail of ovaries.
Excellent. Dr. Sprott, one more question?
Yeah, just to Trevor and Dr. Duhaney again. A number of friends have had stents placed because of issues of angina, and these stents theoretically stay forever.
Right.
But the same thing that caused the occlusion in the first place may occur over time. And the question is, what ought to be done to evaluate folks that have had stents in, just to make sure that they don't have narrowing occurring again in other vessels or in the same vessel?
I think CTA may be the only way for diagnostic radiology to evaluate coronary arteries with stents.
Can you explain what a CTA is, Dr. Duhaney?
Sure. CT angiogram is where the acronym CTA comes from. It involves giving what's called a beta blocker to a patient prior to the study. And when their heart rate reaches a certain level, typically below 60 beats per minute, then they are now ready for a scan. They get a non-contrast CAT scan through the heart, and then they get an injection of contrast, of iodinated contrast, of iodine. And then the study is repeated. The imaging is repeated, and in a rapid pace to optimize what's called the bolus, or the concentration of contrast in the blood, so it gets to the heart at the right time, so we get the right images and look at the lumen of the arteries. Now, it's effective because it's an injection into the veins of your body, which ultimately leads to them going to the contrast going to your arteries.
He has to stay.
So
Absolutely.
and the images are reproduced after the CAT scan that can eliminate other parts of the heart and only isolate the iodine in the artery, so you can see the caliber and the contours of the artery to determine levels of stenosis. Definitely, there's no question that prosthetic devices like stents and other prosthetic devices in other parts of the body have given imagers headaches for decades. Stents are no different, so they're going to affect our ability to perform a non-invasive test to determine blood flow in any given artery that has a stent. Larger arteries, much easier than smaller arteries, and coronary arteries are very small in the matter of several millimeters caliber. So, but I think that's the best chance that we have to see the caliber of an artery with an imaging test, short of digital subtraction angiography or cardiac catheterization.
So Trevor,
Yes.
my cousin gets seen by cardiologists quarterly. Another friend was seen twice a year. But the question is what gets done in terms of that follow-up, because I can just tell you, the one that was seeing the cardiologist twice a year was only getting EKGs post 2019, and he died 2 months ago, massive heart attack, complete occlusion of his LAD.
Very unfortunate. Yes, difficult questions, of course. I think that first of all, in evaluating patients who've had stents, we understand what the stent did and what can happen to the stent. The stent is essentially a small device which is placed. It looks like the spring of a ballpoint pen, for those who think of the old ballpoint pens, the spring. And it generally is covered with, mostly now we use drug eluting. That is those that have a drug enmeshed in it, so that they can elute this over a period of time to prevent one of the dreaded complications of stent implantation. That is, when you put the stent in the coronary artery, we're always concerned about this foreign material inciting the platelets and then the rest of the components of the blood to form a clot. So acute thrombosis or acute clotting of the stent is something that we're very concerned about. Well, we should treat these patients with medication to prevent or to preclude that over the time at which patients are at most risk. Many times you give the patients what we call dual antiplatelet agents, and we don't want to go into details of that, but at least 2 drugs which are given over the period of a year, during which time the patient is most susceptible to these clots forming. So one of the dreaded complications of successful stent implantation is that a clot can form to block the stent and, in a sense, worsen the situation, perhaps worse than it was before the stent was placed. That's a serious complication with major heart attacks and perhaps even sudden death as a consequence. The other complication that we're concerned about with stents is gradual blockage of the stent by the body laying down tissues to gradually narrow the lumen or the opening of the stent. Now, that's a much more gradual process, of course, and the findings and the symptoms that the patient may have are much less dramatic. So how do we detect these? Routinely, after patients had a stent for 2 years, one is entitled to have a nuclear stress test performed. Not necessarily the CAT scan. We've had, again, the question I think we answered earlier of when to do a coronary CTA, a special coronary CAT scan, versus when to do a stress test. And I certainly favor the stress test in terms of the functional information which is given. But also I'm a little concerned about the defects that one may see once a patient has a stent, some scattering of the images, etc. So I prefer a nuclear stress test at a given time in a patient who's totally asymptomatic. If a patient has symptoms that occur, of course, then one would be prompted into doing further intervention, either doing a stress test, or if there's significant symptoms in a patient who's known to have had blockages of the coronary arteries before, one would be justified in going directly to the cardiac catheterization laboratory and getting a picture from inside, that is, cardiac catheterization pictures, where we pass tubes into the arteries. We use the artery at the wrist, the so-called radial artery, or the artery in the groin, the femoral artery. And we pass tubes backwards up towards the heart, inject dye, and there we can take X-ray pictures more directly to give us the details of the degree of blockage, if any, of those stents. But one would, because it is considered an intervention or an invasive procedure, one would do that only if there were clear-cut rationales, such as significant symptoms in a patient who has had a stent or stents placed. Now, one of the things that we must also remember is that placing stents to treat specified areas of blockage in the arteries is not the totality of treatment of what can happen to the arteries in the heart. In other words, you do these pictures and we see areas of the coronary arteries which have a more than 70% diminution or blockage of the lumen. And we say, aha, here's an area that's probably the site of the problem. Let's go and fix that. That does not prevent at all other areas in the heart, in the arteries, other locations from forming new blockages. So we not only look to see if there are concerns with the stents that have been placed, but we also must bear in mind that these are patients who are susceptible to blockages in the arteries, and so we do tests to look for arterial blockages. Again, typically the non-invasive tests that were mentioned, but we do follow these patients closely. I would not put a stent in a patient, knowing that either the stent may be at risk or the patient's coronary arteries may be at risk for further events. Put a stent in a patient and fail to do any evaluation of the patient over a prolonged period of time. I would consider it important from simple electrocardiograms, clinical evaluations, and if necessary, some of the other tests we've mentioned, but I would consider it necessary to follow these patients because the patient is telling you something. The patient is telling you, I am now at much greater risk. My arteries have become naturally blocked. You had to treat them with a stent, and the stent itself may become blocked. So this patient is at much greater risk than the general population and deserves close evaluation.
Excellent.
So when you say close, how often would you say without symptoms stress tests?
No, I would not do stress tests often. I think with 2 years after stents have been placed would be appropriate to do a stress test in a totally asymptomatic patient. If that's negative and the patient remains asymptomatic, then I would not necessarily do another one shortly, maybe another couple of years, 1 or 2 years further on. I would not do routine stress testing. And if I did stress testing on such patients, I would do nuclear stress testing rather than simple exercise stress testing.
Excellent, excellent. Dr. Anderson, and there's a question for Dr. Lee. So Dr. Anderson, I'm going to take your question and then we're going to do this question for Dr. Lee.
I think Dr. Lee's question is more important than mine. Mine is
all
for
right,
Dr.
then that's
Dehaney.
good.
Yeah,
Let's rock and
yeah,
roll then.
yes.
Dr. Lee, it states like this: I had a hip replacement 6 years ago through an embolism. I am now preparing to replace the other hip. I am 83 years old, relatively good health, cleared by cardiology. I am very concerned about this upcoming surgery. Your thoughts?
Well, Omar, certainly would take your input here too, but I would say elective surgery, in this case, you want to make sure that everything is taken care of ahead of time. So I'd want to know, is this patient on a blood thinner? Have they been screened recently? I'm not sure what the protocol is to follow up pulmonary emboli, post-emboli, whether you image further. But I'd imagine if I was the surgeon indicating this patient for hip replacement, they would have to be completely asymptomatic. They'd have to make sure their blood thinner is managed appropriately, and that I would have a letter from someone like Dr. Bay stating that this patient is clear for surgery and their risk is low. That I think is would be appropriate in this situation.
Yeah.
Well, if I may say something, to Dr. Lee's point, this patient he'll get her through the operation. It's what happened in the perioperative period that's important, given a history. The number one risk factor for a blood clot is a prior blood clot, right? And we use, Kevin remind me, the Caprini kind of score, right? For certain surgeries and developing a risk category for patients who are likely to develop a clot. That has to do with patient's age, patient's weight, type of surgery, duration of surgery, and prior clot. And those patients, in the past, we used to even give them anticoagulants, low dose, on their way into the OR, right? And that comes with some acceptable risk of bleeding from the procedure that we're going to do. But more importantly is the risk of developing another clot in the postoperative period. So I would say this person's at high risk for developing another clot. And this person, if there is no underlying issues other than related to surgery that puts her at risk for a clot, should be within a reasonable amount of time, we put back on anticoagulation postoperatively.
Right.
The other thing you can do, and it may or may not be indicated here, is if you did proceed with surgeries to put a filter in her, because that'll prevent, hopefully, the consequences of, the severe consequences of a PE. You can get, post phlebitic syndrome, but the consequences of a PE somewhat may be mitigated in addition to early anticoagulation.
Certainly if she got the embolism again, she'd definitely be a candidate for a filter. And in the right centers, pulmonary emboli can be treated if they're a significant volume, yes. By intervention, not just by passive medication.
Right. The question is, those type of complications for a hip replacement. That was a hip, right?
Yeah.
Yeah.
The thing of it is that also that she had the prior clot, and she's 83 at this particular point. What is her pulmonary functions? What is her chest X-ray? Whether she's had significant shortness of breath in the past? How long ago that clot came about, and whether she was appropriately treated? Is she on anticoagulants now? There are a lot of questions that would come about before you would clear an 83-year-old. My question also would be, if putting in a filter, what are the chance of complication at 83? We don't put filters in as much as we used to. We used to put them in quite often, but Dr. Duhaney, maybe you can give us some understanding of age. Is that related to the complications from the filters that we put in? And those filters sometimes become clotted as well, and then we have the problem going forward. So could you give me some understanding?
And we need to bear in mind that the consequence, which is the term Kevin used, is not the clot so much, but what the clot can do to you. And oftentimes we worry about the clots, in the lower extremities going to the lung. But we also bear in mind, if there's an underlying risk, so for example, some intrinsic hematological risk for forming a clot, then she can clot anywhere. She could clot in an arm, and a filter would not be helpful. So it's a combination of a filter, possibly anticoagulation, that would get her through this. The other thing is, we often focus on a blood clot, but it's the embolic phenomena, meaning the obstructive consequence of a clot that causes a problem. Well, you can have an obstructive consequence by even someone of that age breaking off a plaque from inside of a vessel that will go to a kidney and go to a lung, or even in the heart, and cause a problem. So it becomes a challenge. The good thing is cardiology has already cleared her, so we hope the issue of plaques have been addressed. But certainly the hematologic component is important.
Right. And pulmonary clearance would be appreciated as well. Dr. Duhaney?
Sure. Yeah. I mean, the two main complications for filters are thrombosis and tilt, where the filter actually moves slightly inside the largest vein in your body. So the filters are typically placed in the largest vein in your body, which is in your abdomen, just below the level where the kidneys push blood into that same vein to go back to the heart. And that's done because if the filter thrombosis, you don't want the kidneys or any of the great veins in the upper abdomen to get blocked. But the rates for complications, as far as I'm aware, for someone that's elderly or over 65 compared to under 65 are not tremendously higher for filter placement. They're in the low teens for younger patients or patients below 65, and they're in the mid-teens for elderly patients above 65. So getting a filter, as long as they're not anticoagulated, should not be a major issue for an elderly patient. And today's filters are far more sophisticated than they were when I started.
Right.
And I put filters in before. They're easy to do, but in the right.
They're retrievable too, right?
What's that?
They're retrievable too.
retrievable.
The new ones are retrievable.
Yeah.
Absolutely.
All right.
And there are temporary filters also that are retrievable. So.
The one point I would make, just to emphasize, so we treat based on the physiology, not just the age. So even though she's 83, physiologically she could be 63 or 70.
That's correct.
So we always look at that as a feature rather than her age, because we operate on patients in their 80s and 90s, as long as they have a reasonable expected postoperative outcome.
I mean, I'm not an interventional radiologist, but I'm an old school neuroradiologist. So all neuroradiologists had to do 100 brain angiograms and 100 brain angiograms and 100 neck angiograms and 50 myelograms to get certified, or to be able to sit for the certification. Today, that's not the case, because we simply rely on imaging instead of diagnostic imaging instead of diagnostic intervention, diagnostic angiography to look at these vessels and to look at the spine. And so when I started practicing in the beginning of my career in New Jersey, then I was in a small group and we had to do everything. So I had to learn. I ended up learning a lot of interventional techniques because once you started handling catheters in a cath lab, that's translatable to other parts of the body easily. So having said that, I put in a lot of filters in the right situations. Under most situations, they're a 20-minute process or less, depending on how good your supporting staff are in the suite. But maybe a temporary filter is the answer for her, for him, whoever is getting the other hip replaced.
Right. And she stated that she was in good health, reasonably
Right.
at this particular point. There's a last question I'd like to handle. How does the panel feel about de novo scans? People are paying for to get full body MRIs. So are these just full body scans that you can scan someone and say you're good, you're healthy, you'll live for 100 years?
I mean, yeah, the so-called executive health screenings. Yeah, those have been going on for a long time now. This is not a new thing. It may be new that they're doing MRI. It used to be just CT, now it's MRI. I mean, I think your risk factors for developing a cancer are more important than just doing that off the cuff. I mean, if you smoke, if you drink heavily, if you participate in other things that put you at risk for developing cancer, you have a ton of fragrances running out that you're breathing constantly every day, which is a significant thing that is becoming known to the public, that fragrances are toxic. Then maybe you should have some imaging. But I think that it's, personally for me, I think it's a bit on the ridiculous side, because if you are conducting your life in a way that optimizes health, then that's more important than the screening part. Now, yes, you can spend money and get the imaging. You're going to find things that are going to raise your anxiety level at some point for a certain percentage of patients, and those are going to be meaningless. And those are what we spoke to earlier in the conversation, called incidentalomas. Your body's not perfect. Your body doesn't read the book and how it's supposed to perform. There are things that happen in your body that create minor issues that pass, that are meaningless, except that they occurred. Those are you're going to run into far more often than something real. The things that we discussed, like low-dose chest CT for smokers, whether you quit or not. I think after 15 years, your risk of developing lung cancer is so low that it's not worth screening any longer. Screening mammograms, all the screening tests we've talked about are important for the patients that are in those categories, meaning by age or by behavior, require that kind of screening. Like if you're 40 or older for a mammogram, if you smoked for the low-dose chest CT, if you have a family history of aneurysms in the brain, for instance, you can get screened for that. If you have specific diagnosis that lends itself to other problems, yes, you should find screening. I don't believe in whole body screening, but if you have the money and you want to spend it, that's your decision.
Sounds good. Sounds good. Well, we've covered a lot today. Dr. Duhaney, it was excellent, and thank you very much for coming on. Man, what a coverage.
Hey, this is the first all-black panel I've been on anything, and it's a pleasure. I don't work that far from you. I don't actually live that far from where most of you guys work either. I have a colleague that just switched over to Beth Israel in radiology, but it's been a pleasure. And I hope to join you at the forum again. It's an excellent forum.
Believe me, you will. And I'll be talking with you about that. Also, the brother that you stated in pulmonary critical care, offline, give me his information. If you think he'll, I'll contact him and see if we can, get him on, because
I think he will. I'm pretty sure he will.
All righty. Sounds great. Sounds great. I'd like to say that next month, I'm excited about next month, because we're going to end the year with natural medicine. Just to let everybody know who's listening, natural medicine, holistic medicine. There's a colleague, Dr. Patrick Anderson knows him very well as far as because we're going to be on the same panel next week or next week, Patrick.
Right,
Don't we practice
right.
natural
It's gonna be
medicine?
fun. Oh, you're going to be there too,
Well, we
Kev?
do. We
Isn't
do.
that what we're
But
doing right now?
Well, Dr. Kevin Holder is someone who went to medical school with me. And once he came out of medical school, I went and did pulmonary and all of this. He did right out of medical school and out of residency. I should say right out of residency, he did natural medicine, and he's been doing that
Pediatric
for
residency.
many years.
Omar, pediatric residency.
Oh, pediatric.
I thought he was med peds.
Well, that's what
I think he was. Yeah, he was
I only
med
count the pediatric part of the med peds.
Right,
Oh,
right.
okay.
So we all know Kevin. So
He trained under
he has
me.
been doing holistic medicine for over 35, at least 35, 38 years, because I've been
Always
so
a good
we're so
discussion.
excited to have him next month. He's coming on and he's going to be talking with us about all the things that,
Yeah.
things like Bush tea.
Well, Kevin is very opinionated. We've managed several patients together. But he's reasonable in his opinions, and which is that which I respect so much about this gentleman. Very reasonable, very patient friendly. I mean, very approachable.
Right.
You'll see him in the supermarket and he'll tell you about what vitamins you should take and the source that's the best. He's an
Kevin.
incredible individual.
Oh yeah, I think half my patients go to him.
Wow.
To tell you the truth. Oh boy, as far as our culture and natural medicine, it's a match made in heaven. So we really need to know more about it, and so happy that he'll come on next month and be a part of our panel. All righty. Let me close out here. Thank you, OBHealthy, for allowing us to bring this platform, use your platform to bring our webinar to you. And I'm just so appreciative of everything they do to help us out. Remember, our webinar is every second Saturday at 1 o'clock. And if you would like to see our past webinars, please go to OBHealthy's website, hit the YouTube channel, and all of them will come up. So interesting, all types of topics. Caring and sharing. Hey, listen, let your family, friends, church members, even your enemies know about what we're doing here. And we'd love to have them and answer their medical questions. The most important thing that I can say today is please do not change any aspect of your medical care until you consult your physician. Only your doctor, truly only your doctor, can best take care of you from a medical standpoint. All righty. And thank you again, everyone, all you brothers. I'm just so happy that we're continuing this. We're going to keep rocking and rolling. We're going to keep this train rolling. We're going to educate. We're going to do what we can for our people out there. So Thank you very much, each and every one of you. I will see you next month. Enjoy and peace.
Sounds good.
Peace,
say.
guys.
I'm gonna give you a call.
Have a great weekend.
Take care, everyone. Take care.
Bye, everybody, and happy
Bye-bye.
Thanksgiving.
Bye-bye.
All right.
Happy Thanksgiving.
Bye-bye now.